the first thing is just to say from NHS England's perspective, it's a great privilege to be asked to present here. And I think one of the things that all the way through this presentation, we're as keen to understand from you what we should be doing. I think in terms of where the NHS is right now, there's never been a time where we are as willing, potentially a bit needy, to work with people in areas like yours to understand what we can do differently within the NHS. The title for this presentation was not one that I gave it, but actually I think it's incredibly interesting and almost hypothesises exactly where we are. It's called Measuring UK Patient Experience, Measuring, Using It and Co-Designing Service. Now actually, if you go through those three things individually, we become less good at them the further we go through. And that's a really interesting hypothesis all the way through this presentation is, to what extent are we very good at just measuring, of doing more data, of trying to understand more, and not so good at actually using it in co-designing services. And actually the skill set in this room is something that we need to harness to understand, well, what does this mean? What do we do with all the data we collect? So in terms of that, I'm going to go through a few things. The first thing in terms of this is that the NHS at the moment has recently published a thing called the 5-year forward view. So what's fair to say about the NHS is it's constantly in transition, it's constantly in change. But I think with the 5-year forward view, what we're trying to do is lay out a programme of work which will take us to where we want to be. And I think in terms of this, the first thing is to think about the NHS has achieved a lot, currently ranked #1 healthcare system in the world by the Commonwealth Fund. More than 2/3 of the UK public believe the NHS works well. An extraordinary figure from polling data from a previous life is that 1 in 2 people in the UK think the NHS is the thing that makes them proudest to be British. Now, when you mention that internationally, to think in the US, for example, how many people might say that of an HMO, it shows you. Now, that's great in terms of the absolute devotion to the service, in terms of that thinking that it is one of the things that we can be most proud of, but it makes it difficult to change it. It makes it difficult to say, how do we move the NHS on? Cancer survival at its highest ever, operation waiting lists are down, early deaths from heart disease down, more nurses, more doctors, single-sex wards implemented, but, and this is the case for change, we're facing a rising burden of avoidable illness across England. 1 in 5 adults still smoke, 1/3 of people drink too much alcohol, more than 6 in 10 men and 5 in 10 women are overweight or obese, and 70% of the NHS budget is now spent on long-term conditions. And the key thing is that people's expectations are also changing. One of the most difficult things from a research perspective is how do you measure how they're changing? But we know they are. And I think in terms of putting this presentation together and speaking to various colleagues about the subject and what we were trying to get across to this audience is that there's a few things that we're trying to do, and they can be summarised in 3 gaps. The first one is the prevention agenda. The second one is what we're calling new models of care. And this is something where we're extremely interested to work with others to understand what can be done in this area. That we're moving away from that traditional model of the GP and the hospital to explore what can we do that's different. How can we explore multi-care providers? How can we explore primary and acute being in the same place? And this is something that I wanted to impress upon this audience in particular, and then there's no getting away from it, and it's the same with many healthcare systems, there's the funding issue. And there's always the kind of more for less argument. So I think in terms of where we are on this, and again, we would absolutely welcome if people here had ideas on this and wanted to get in touch. The first thing is the developing new care models and taking decisive steps to transition towards better care models. And this is also, and part of our job, is how do you take people with you? So certainly in the UK, when you speak to people qualitatively about the NHS, they talk about GPs and hospitals. And increasingly in out-of-hours care, the model is very different. It's becoming increasingly fragmented, and pathways are complex. And that's part of our job, is how do we take people with us as well. But there is a wide consensus that new care models need to manage the systems, deliver more care out of hospital, and integrate services around the patient. And again, just speaking to John, that this may, when you say this, it seems an entirely straightforward proposition that you would integrate services around the patient to potentially this audience, not to everyone, that this is not second place that it happens. And again, back on this audience, learning faster from the best examples around the world. And we're already starting this, but again, we would welcome thoughts on what you know and what we can do. The key thing here is that it's not, the NHS serves 53 million people in England. And my colleague Kath Evans up there would say 25% of those people are children and young people. It's not a one-size-fits-all approach. So there have to be models that we put in place, but it cannot be also 1,000 flowers blooming. So what we're trying to do is put new models of care in place, and the key thing is evaluate. Understand what's working, for whom and where. And I'm also going to just talk briefly about healthy new towns. Now, if anyone asks me a question on healthy new towns, I will, just to be clear now, not be able to answer it. But the reason why I wanted to say it in front of this audience is that in speaking to colleagues about what should I be discussing with you, this is absolutely clear that this is what we want help with. And it's an initiative that I thought you'd be interested in. The idea, and we're currently in scoping phase, is the aim of the New Towns programme is to identify and demonstrate additional health and care benefits in the new build developments. So this is about upstream thinking in early stages in town planning, in early stages in terms of how things are being developed. What can we do differently? And one of the key things there is to identify what additional value could be achieved in the health and care sectors in new build developments when freer from legacy constraints. So it isn't how many people, how many GPs, it's how many people, who are they, what do they need, what age population are they, what backgrounds are they from, and starting from that premise. We're at very early stages in this, but the idea is that what additional value we can support in new builds could unlock. So it's everything from the public health agenda through to how do we design services based on this. And so this is an initiative in its very early stages. We're currently scoping what could be done. We're trying to identify sites that we can work with, and we're identifying ideas that we can try and bring to those sites. So I really wanted to impress upon you the importance of this development. And I think, again, this is the package of support, will be co-designed. The key thing here in terms of this audience is the open source design challenge and access to leading designers and architects to try and bring people with us. And it's great that we've got such an international audience. And looking through the abstracts in the last few days, unfortunately I wasn't able to be here, but I followed it on Twitter. There's huge amounts of thinking here. And one of the challenges for the NHS is always how do we bring that new thinking back into the system? Okay, so that was our plea for help. I'm now going to talk a little bit about my job in particular and insight and feedback. And I think one of the things that we're trying to do in terms of setting up NHS England is that actually, in order for us to do much of this, in order for us to initiate change, there's lots of different cornerstones that we need, and one of them is data and intelligence and understanding what is actually happening. The other one is bringing the patient voice and insight back in, and I think you would have talked about it. It's also the idea of customer choice and control. How do you make someone become involved in their care? How do you bring someone into that partnership and change that asymmetry of information and the slightly paternalistic model that I think we've had for a long period of time? So, in terms of my area, so I'm head of insight and feedback. So I would almost start with the hypothesis that the NHS is brilliant at collecting data, which is great until you ask people to use that data. And we're in a very interesting period right now, which is, I think, best characterized by signal and noise. That it's becoming increasingly challenging for people to think which data set do I use and where to evaluate what with whom, and where's the narrative in between all this. So I've worked in many sectors. I worked in the private sector, I worked in academia, and I worked at a social research unit in terms of working on behalf of government. And now I'm in government, and I wanted to find out whether all those data sets that I'd been working on in the past were being used. So I won't comment too openly about that, but we're not wringing them dry. We're not really trying to get the absolute extraction out of them. And that's one of the things that I think we should be working towards. How do we extract the meaning from that data? We're asking huge numbers of people, lots and lots of questions across lots of areas, and it's fantastic that we're doing that. But the key question is, how do we do this? And I think one of the interesting things for me is that the private sector is very good at listening to what the data shows, and it's everyone involved. So it's the product designers, it's the PR, it's the marketing, it's the comms, it's everyone involved in it thinks they have to understand what that data is. Whereas arguably within the NHS, it's not everyone thinks that they need to be bringing that voice in. Often, and I've got colleagues from patient experience here, often it's almost thought, well, that's a patient experience issue. That's not for all of us. So the first thing is about how do we get people more engaged in the data. The other very interesting thing in the NHS is that we tend to listen, when we do a data collection, we tend to listen for what it doesn't tell us rather than what it does tell us. So when we look at a data collection, we often think, well, what's wrong with it? Now, all data collections are limited by their very nature. There is no perfect data collection out there. So we should always be listening for what we can learn rather than listening for what it doesn't tell us. And the key question is, what do we do with the data? And again, I think in terms of working with different audiences, and again, this one, there are some audiences that feel much more comfortable with saying, okay, well, what do we do now? What's our next step? And often if data sets are used for things like performance management, we're not then therefore comfortable to say, well, what do we do to make it better? And there are different tools that are more appropriate for some uses than others, some that we use for evaluation, some that we should be using for service improvement, and we need to be clear on what that data set means. But I think from the Berwick report, the most important single challenge in the NHS is actually the idea of continual learning, that you're constantly trying to evaluate what things are working. It's not you do the evaluation once and then finished, we're off. It's that you're constantly trying to learn from the data. And this is a quote from Daniel Kahneman, who is an expert in behaviour change. This is from a book called Thinking Fast and Slow. And the reason why I wanted to stress this is that he says the confidence that individuals have in their beliefs depends mostly on the quality of the story they can tell about what they see. Even if they see little, we often fail to allow for the possibility that evidence should be critical to our judgment is missing. What we see is all there is. And often, this happens with, we may be being filmed, but I'll talk about it, that often with senior policymakers, you base it on your immediate experiences. You base it on what you see around you. And the key thing is, who do we not hear from? And that's why we try and do this. This is why we try and do this, to understand where those access points are working well, to understand where they're not working well. And this is why we try and impress upon people the importance of collecting it. We run something called the GP Patient Survey, which we send out to 2.4 million people a year. We get 900,000 responses. And there's lots of GPs that will say, well, I don't need this. My patients really like me. They buy me a bottle of whiskey every Christmas. And then the question is, who doesn't buy you the whiskey at Christmas? Are you aware of that? And that's why we do it. Just to really get that point home about why do we try and collect this data. It's because we will always be biased by what's around us. It's availability bias, and we should always be pushing to understand more. So in terms of the patient experience data, there's lots of things that we should be thinking about, and I'll come back onto the staff, but there's the patient focus, the staff focus, the organisational focus, and the commissioning. And commissioning is becoming increasingly important in the NHS. The extent to which you build this data into how you commission services. So it's not just the finance, it's not just the targets, it's actually how do you build experience data into what you're commissioning in a health system. So these are the national patient experience surveys that we run, and you can hear we're hearing from 1.5 million people a year. And again, the offer is there to this audience that that data is routinely available. That data is available to anyone to look at to understand what's working. You can cut it by various different ways, by hospital, etc. So of these surveys, the question for you is, if you had to choose one survey to measure quality by, which one would you choose? You can have one survey, and that's your only survey that you're allowed. Which one would you choose? Whispering is not so good. Right. GP. Keep going. The reason I'm saying this is keep going. Staff. Who said staff? Full marks. So our Chief Inspector of Hospitals, Mike Richards, plays a game which is only played by probably about 10 of us in Anoraks called Desert Island Surveys. And I introduced this game publicly because I think it's something that I like and I'm unashamedly geeky. But the reason why the staff survey is so powerful is exactly the reason that John mentioned in his introduction, which is that good patient experience correlates exactly with good staff experience. It is exactly it. The regression line makes us geeks very, very happy. We have an R value that makes us kind of think, oh, that's perfect. It's about 0.8, 0.87. Now, it makes intrinsic sense to me because if you are a member of staff and you are not recommending care in your trust, that's a big thing. It's a really big thing because you will see an average in a year, 500, 1,000 episodes of care. You hear the whispers in the staff room. You hear what's happening there. You kind of know what's going on in your organisation. You understand the culture. Whereas an individual will just see one patient, one experience. They may have a few when they're there, but broadly that's what you're getting. And I think, again, when you're thinking about design, when you're thinking about co-designing services, when you're thinking about working with buildings, to really be clear on that staff survey, to be really clear on how are we working with staff, not just patients, to work through this. And I thought I'd show this in terms of why we do these surveys as well. There was a big initiative that people will be aware of around mixed-sex accommodation a few years ago. Now, the inpatient survey that is taken from, did you share a sleeping area, for example, a room or bay with patients of the opposite sex? On the y-axis, you've got no, the percentage of people that said no. The reason why we measure these things is because we will do things that we can measure, and we will push where we can. And at the same time, so you're aware, overall satisfaction was remaining fairly flat across this survey. So it shows when we're focused on initiatives that we can do them, and these allows us to evaluate the extent to which it's working. I also, in terms of this audience, looked through all the surveys that we do and wanted to, again, this is about making this data available, show you the extent to which we're asking about a wide range of different things here. And even just on some of these, I think it's very interesting about, say, for example, things like noise levels. So over a third of respondents, 39%, stated that they were bothered by noise at some from other patients and 1 in 5 from staff when they were in hospital. And it's, again, what can we then do with that data? It doesn't tell us why, it doesn't tell us where, but we can look at it. But it does establish what one of the challenges is in terms of patient experience. And that's about getting as much information as we can. So I'm sure you've talked about integrated care. The biggest challenge for us right now is actually how do you measure across a pathway? How do you measure people going through a system? Because we tend to draw the sample from the GP practice, we tend to draw it from the hospital, and this is something that's really facing us right now. And if anyone's got examples of this, we'd be delighted to hear. How do you track something? We know that much of the patient experience challenges are in transition, whether it's from children to adulthood. There was a very interesting piece of work I heard in terms of qualitative where someone said they were in paediatric care and moved to adult care. They felt like they'd been thrown out of the health system. And those are the challenges. It's those transitions, at discharge from A&E, at discharge from inpatient. So the other thing that we always have to be aware of is that this is from the GP patient survey, and I'll just go through this in a bit of detail. This is how would you describe your experience of your GP surgery? This is 18 to 24-year-olds over here. Okay, this cannot just be because they might be a little bit moodier than some of the other older members of our population who become increasingly, how should we say this, not resigned, but maybe a bit more sanguine about life. But anyway, you can see that actually the older you get, the more the satisfaction goes up. Now, there are various reasons for this. Okay, go on.
I'd say it's more the dissatisfaction is increased and expressed.
Yeah. And also there's a lot of things around access here. That the further you go along, as soon as you retire, access actually becomes a lot easier in terms of when you can get in and appointments and so on. But the big question is, if the quality of care is exactly the same, is it expectations as well? And one of the very interesting things, so when we're looking at insight data, it's always asking the question of why? Why might this be going on? And this is from the British Social Attitude Survey. And this is how satisfied or dissatisfied are you with the NHS as regards local doctors? Now, that top line is the pre-war generation. This is Generation X, Generation Y, and the baby boomers below. And what you can see on this is that this is a perfect kind of line, it always remains higher. The dips kind of go along nicely, but it always remains higher. And the pre-war generation is the last generation that remembers an NHS, the time when we did not have an NHS. And one of the increasingly interesting things for us is that clearly this population is dying out now, and we're faced with a new population with new challenges in new ways. And it's starting to think, how do we understand that in a meaningful way? So one of the things is that actually, from my perspective, very interesting is that people become quite fixed on, well, which is the best collection method? And I think where we're trying to get to is that there's lots of different collection methods. There isn't a perfect one. And I think often we are rooted in surveys because of social science. We feel that we need to have the right confidence intervals. But actually, one of the interesting things for surveys is that we choose what we call, and apologies for language here, I'll try and explain it, but a sample approach. So we go to a sample of people. It's not for everyone. And interestingly enough, I always thought, oh, this is great. You know, we get the sample, we work out the confidence interval, we understand the p-values, we understand the... But actually, there's something about not being asked. And on the staff survey, in many trusts in the UK, people do not think random probability is random. They think it's fixed. They think we ask people who will give us a better response. Particularly when someone was telling me this recently, said, well, look, every year the 2 directors in my area get asked the staff survey, I've never once been asked. It's like the classic political polling, I've never once been polled. It's that thing. So increasingly what we're trying to do is understand how do we move away from that. And there's a recent initiative here, which is the Friends and Family Test, and I can go into this in terms of questions or I can speak to people in the break. But the idea behind the Friends and Family Test is it's not a survey. It's a feedback mechanism. And it's available to anyone. The other big thing with it is the qualitative feedback. The why is really important. And to give a couple of examples, there was an A&E consultant who, at the end of every day, and we'll talk about the real-time thing in a second, the end of every day, would look through all the cards they'd got in that day. And just to be clear in terms of the NHS, that is often under a lot of fire, and staff are under a lot of fire, the vast majority of feedback is very, very positive. And I think the other thing we should be aware of in this, in terms of organisational development, is it reinforces good behaviours, as well as saying, well, what should you do to improve? And we forget that sometimes in terms of management techniques. That telling someone what they did well is a very powerful management technique, and this allows... So I spoke to a nurse of 20 years who said, look, I've never known when I was doing the right thing, when I was doing the wrong thing. This has told me and actually makes her feel very proud for doing the work that she's doing. It's not without flaws, but the other big thing about it is the real-time nature. And the A&E doctor, good. Toys are dirty in the A&E area. Now, it might not sound like a big thing, but it is a big thing in terms of children. About making sure that parents feel comfortable and they've got that place to leave them. And this is about how do we start to harness this data set a bit more. The other thing is that on those surveys, there's often we collect the data and then we publish the data 6 months later. For various reasons, in terms of statistical analysis, cleaning it, making sure it's not biased. But what it means is that you're not proximate to what the problem was in the first instance. And so it's the real-time nature of this feedback that's important. So far, I think we've got up to 8 million responses. And again, if people are interested in this, I'd be delighted to think about it. In terms of within a trust, there is something very interesting about working and saying, well, what else could we do with this to evaluate different wards? How can we evaluate different interventions within a trust? And I think there is potential for this in terms of other questions. So again, it's a call out that we would be delighted to work with people on that. And again, just in terms of environmental issues, I mentioned the problem about noise at night. These are direct interventions that have come about as a result of the feedback from the Friends and Family Test around quiet protocols around noise at night. So the other big challenge we face is that, back to this idea of the NHS is awash with data, there is huge amounts coming in from the more sort of qualitative end, the surveys, the Friends and Family Test, patient stories, which are an incredibly powerful agent for change. And our view is that we should start to understand how we use them together, not right or wrong for different purposes. And I think this audience, again, may be more aware of this than many people in the NHS, but increasing the behaviour change work is that it isn't just about asking. Because we often think we need to ask people what they want. Now, Actually, that's one element. And a much more useful paradigm for this is normative need, what we think people might need. Felt need, what they tell us they need. And express need, which is what they actually do. And to give a really good example of this on the 5-a-day program, 5 a day in terms of fruit and veg, I did a piece of work evaluating that where awareness of 5 a day had gone up, consumption had gone down. Don't tell who? Yeah, just don't mention it. Awareness drop and then again. But it's really interesting, isn't it? It's not just about judging. We need people aware of this. We need to actually be measuring what the behaviour change is. And that's the express need. And a piece of work I did in Royal London a while ago on alcohol interventions in Royal London. And there were 2 nurses there. There was a psychiatric nurse and a diabetes nurse who were affiliated to the A&E. Both of whom, when we asked them in the interviews before the observational work, we said to the consultants and the doctors, do you use these nurses? Yeah, all the time, yeah. You know, they're great, really part of the team. And then we spent days with them, following them round on shifts and realising how hard they worked and becoming very tired. And what became increasingly clear is that they really worked a lot with the diabetes nurse and they didn't work with the psychiatric nurse. It was only because the psychiatric nurse was 2 corridors away down the double doors. And they are time poor. And the diabetes nurse was positioned right by the desk and they just worked with her straight away. And that's about the making it easy. It's about observational work and not always saying, what do people want, what do they need? And so I think, you know, no doubt people in this room will be aware of this project. Can people just put their hands up if you're aware? I'm just interested in this. Yeah, so I won't go into huge detail, but the key thing for me was the observational element. It's about the clear experiments that if you say to someone, if you tell them how long they're going to wait, they will be happier than if they have to wait less time, but you don't tell them. You know, it's about experimenting. And on that note, I wanted just to show you an experiment that's been done recently about non-attendance. So this is the did not attend rate. Okay? So there are text messages going out from hospitals. This is a piece of work that was done by colleagues in the Department of Health. Not published yet, but I've got permission to show it. I think it's very interesting. It's about which messages work and not saying to people, tell us which one it works, doing the experiment. So the first message, which is the sort of standard one, is a reminder. You know, okay, you're due in. Here's the, to cancel, call the number on your appointment letter. Now in that one, you're already saying the number is slightly removed, you've got to go and find your appointment letter, you've got to go and... This one says, we're expecting you at St Bartholomew's Hospital, not attending cost the NHS £160. Call this number if you need to cancel or rearrange. Now, there's a 3% difference in terms of the DNA rate. Now, it may not sound like a huge amount, but extrapolating on finance, it's looking at something like 50 to 200 million pounds. So that is what we need to be thinking about, is not just insight and feedback, asking, it's experiments. And I think with this room, I'm hoping that this is the room where we can start to think, well, how do we do these experiments? How do we work with you to start these experiments? And we do collect the data on what people want because it's important, but we realise it's not the only thing. And these were some, I won't go into this one in terms of time, but these were some of the other ones, and you can see there were various initiatives. So, almost starting to sort of summarise a few thoughts on this, and even putting the presentation together, there's just huge amounts that we could be talking about with this audience. And very happy to pick up in separate conversations. But one of the big issues is we often work with doctors. Doctors are rooted in randomly controlled trials. P-values, confidence intervals, understanding, da-da-da. You present qualitative data, and there will be, well, what does it tell me? And actually what it tells you is huge amounts, and it's just different. It's not right, it's not wrong. But what we've seen from the survey data about the awareness of 5 a day is that that isn't necessarily right, but we're in a positivistic world in terms of data. And actually we should be looking at what can we get from all these different sources, given the investment going into them. There's something very interesting, which again, I think in terms of this audience would be very interesting to hear from, is that there's increasing evidence that the more you're engaged in the research question at a very early stage, the more you will pay attention to what comes back in that data. If you impose a survey on someone and ask them questions that you decide are the right questions, it's very different from actually getting someone to design that survey at a local level. And that's about if you're doing evaluations, get everyone in the room as early as possible to think, what are we asking, why, and with whom? And again, this is about data being presented back appropriately to each audience, and we're not great at this. There is an argument that many of the data collections we do are very good for academics, and are very good for the Lancet, and are very good for the BMJ. They're not great for patients. And this is the balance that we're trying to strike in terms of some of this work. And I just wanted to show you this slide because this is about presenting data with impact. And this is a slide that I saw at the Nuffield Trust. Has anyone seen this slide before? Okay, so the red dot up there, has anyone got, this is about a patient with Parkinson's. And she's had Parkinson's for about 15 years, and she was doing a presentation on the extent to which she was involved in her own care. So does anyone hazard a guess on what that red dot means? Sorry? That's the hour in every year that she spends with clinicians. The other 8,700 is when she is looking after herself. Now, the reason I show this chart is not just because of patient involvement. The reason I show this chart is that I've never forgotten it, because it's data with impact. And again, I have a huge vested interest in, and I self-declared my wife as an architect, and when I show her some of the data presentations and PowerPoint slides and things we put together, she does her best not to be mean, but it's there. And how do we work with you to present data with a change? Data for change. So if I feel I've done my job well in a few years' time, or next month, or tomorrow, depending on political masters, I'm going to finish up now. But you know, the key thing is, how have we done this in terms of data change? So for your final thoughts, I think we've been through them. You're involving patients as much. I think it's training people to use the data. But the key thing for me is engagement. Ownership of these data and understanding what it can tell you and what it can't. Great. Thanks very much for your time.